Good morning, everyone, and welcome to the meeting of the Audit and Performance Committee of the Perth and Integration Joint Board for today, Monday, the 29th of July 2024. There is one single item on the agenda today, and that is the annual performance report for approval. I would like to, first of all, ask if there are any substitutions or apologies for today's meeting.
Thanks, Chair. Morning, everybody. We've only had one apology this morning from Bernie Campbell.
Thank you. And are there any declarations of interest from anybody in the room or online? I don't see any declarations of interest. Then I'll move to the presentation of the annual performance report for 2023-24. I'll ask Chris Jolly to introduce the report, please.
Thanks, Chair. Good morning, Audit Performance Committee. The Public Bodies Joint Work in Scotland Act requires integration authorities to produce annual performance reports within 4 months of the end of the financial year. So that's the 31st of March. So thanks for having this meeting this morning just in time. I'm therefore pleased to present to the Audit Performance Committee this annual performance report for 23-24. In presenting this report, I would very much like to thank all of those who contributed to the production of the report, in particular Claire McCarthy on my right, who's done much of the production, service colleagues for their content contribution, and Robin Kinnear for his assistance in developing this final version with infographics and other design features. The context in which health and social care services delivered in Perth and Kinross is one of an ageing population, a diminishing working age population, a challenging financial environment, and with some difficulties in recruiting to some key posts. Against these challenges, however, we've achieved a great deal, and this has been seen in the overall performance measures, where flow through inpatient settings has improved. This is a good proxy for us to consider the impact of the service changes which have been made and are being further implemented to support people to remain at home for longer and to diminish the need for inpatient care. The annual performance report sets out an overview of performance in relation to the national indicator set, with the majority of indicators indicating good progress, and these are supported by supplementary performance information throughout the document. The report describes in some detail the activities of delegated services, the impact they have on supporting people in Perth and Kinross and provides an overview of feedback received from the people that use our services or their carers. Through different feedback mechanisms, we can see that people rated services at least 4 out of 5, and that 97% of people rated their service as good or excellent. We have noted that emergency admissions and readmissions are areas for improvement, along with the need for people to feel that they have more of a say in how they are supported, and the need for people to feel that the services are better coordinated. These are areas that are already being taken forward, been identified within our newly approved IGB's newly approved strategic plan. We have appointed 2 posts within our strategic leadership structure, which will help with these factors as well. And recently conducted commissioning of additional and new care at home providers, which will improve resilience and greater accessibility. I'll just end my introduction there and seek questions.
Thank you, Chris. Then if I'll ask for questions in the room first, if you want to just raise your hand, since there are so few of us, I think I'll see you, and then I'll come to those online. So anybody in the room with a question?
In the indicated descriptions, all the red areas are, or 2 of the red areas are around emergency admissions to hospital. Could that just be a function of our high age profile within the area?
Yes, and as a short answer, we know that with increasing rates of frailty, the propensity for the need for emergency unscheduled care will increase. And with Perth and Kinross's fairly elderly population, and the growth in the size of that overall aged population leads us to a situation where the need for emergency care is likely to increase. What we're trying to do, however, is do what we can in order to support people to remain at home for longer, and to improve our community-based services to the point where that is limited, so that inpatient care is limited in its need.
Thank you, Chris. Does that answer your question, or do you have another? Jackie, would you like to come in as well?
I think it's also just worthwhile for the committee to note that the national indicators relate to the rate per 100,000 population for emergency admission for 18 plus, and I think as a partnership and as an IJB, we need to be thinking much more around how do we differentiate and segment our population so that we're absolutely clear about what we're talking about here across the age range. So that's maybe something that we can come back and show, and demonstrate for you what that means for the 18 to 65, the over 65s and the over 75s, because I think that's important for us to recognise where the differences are.
Thank you, Jackie. That's a very important point, I think, because we do tend to focus on the people who are most likely to use the services, but there is others as well. Does that answer your question, or David, or give us? Okay, and then we'll move to the.
In the whole report, there's not a mention of realistic medicine, and that's a subject I know is close to Beth's and mine hearts. So I just wonder if any thoughts about that.
Yeah, thanks for the question, Councillor Illingworth. You're right; it's not something that's mentioned. We do have within our primary care section, transformation. Sorry, within our portfolio, our transformation portfolio, we have a primary care and a prescribing project and programme called QSEP, which is the main focus of bringing realistic medicine. I'm not sure whether there's an opportunity for primary care colleagues to comment on that more fully at another time.
Just something for us to think about in terms of our presentation. So thank you very much for that comment, Councillor Illingworth, because when we talk about realistic medicine, there are lots of references to prevention, social prescribing, etc., which are very much related, but we're maybe not using the terminology. So it's maybe something we need to think about. So thanks for pointing that out.
Beth, you have a question?
Thanks very much. It's more an observation rather than a question. I think, Councillor Illingworth has pointed out about the REDs, and they're around emergency admission at home. And then if you look at the REDs and the people's feedback, it's about the percentage of people at home who agree they're looked after. It's just, are we clear that we are not going to be subject to criticism, those linked directly to a hospital at home service, which we've modified, and it'll be clear that we've got enough there to cover our changes in our direction, if that makes sense.
Thank you, Beth. Who wants to answer that one? Chris?
So there's quite a complex question. It's quite a complex question that I'll try and simplify the answer. So there are obviously a number of measures in terms of national indicators that are presented here today, and it can be challenging to tease out exactly what's underlying those things. What we do have is, in terms of supplementary indication, in terms of how those things are broken down a little bit more, and perhaps it comes back to the point that Councillor Illingworth made a moment or two ago, in terms of the strategic delivery plans that we have in place that sit underneath our newly approved strategic plan. There are opportunities for us to explore how those delivery plans are put in place for each of the individual care groups. And I think that's where the opportunity will be to explore where the alternatives are to the service provision, subject to the decisions that the IGB's made about investment and disinvestment. So I'm not sure I can give you a definitive answer to your query, but there are a range of layers of other areas within health and social care that are being delivered, particularly through those strategic delivery plans, that I think will be examined by this committee over the course of the next few years. It will be actually.
Thank you, Chris. You can.
Yeah, I get what you're saying. I think my concern, I know this is retrospective information, and we're looking at where we go forward. I'm just highlighting that it's good to be prepared to know that overall our decisions were based on something that wasn't working, well, proven to be working so well in our performance of the last year, and going forward when that's a key area of people staying in their own homes. So thank you for your answer.
Thank you, Ben. Okay, thank you very much to Councillor Illingworth and to Beth Hamilton. Now, for those joining us online, if you can raise your hand if you have a question. Martin Black, please.
Here, I've got a few questions, but I could take them one at a time if you want, and let other people in. But I've got a few questions on there. Well, a couple of observations and questions.
Just take them as they come, Martin.
On page 6, I'm sure it is, it's shown that the multiple deprivation indicates that nearly a quarter of the population live in the least deprived areas and 6% in the most deprived. How is that in comparison to Scotland? Because it's not really telling me an awful lot. And the same with the 21.6% of the population have one long-term condition. How is that in comparison with Scotland? Because then I could have a better understanding how well we actually are doing or not doing. Yeah? That's the first one. If you want to answer that, then I'll go into the next one.
Thanks, Martin. Chris, do you want to do that, please?
Thanks for the question, Martin. We can send that information out and share it with the committee. That's readily available. The data that relates to the demographics of Perth and Kinross is produced by Public Health Scotland, and there are key comparators between P&K and Scotland, so we can provide that outside the committee.
Thank you. The next question, Chair, is on page 7 or 17 and 72, and again it's emergency readmissions. If we look at the indicator 14, for 7.3% people going back in within 28 days, but when we go down to item or NI 19, then it's showing that we're at 29% in the green. So we seem to be having 29% in the green, but we're firing them out, and 7.3% are back in within 28 days. Does that need to be looked at? Are we putting people out too early?
Thank you, Martin. Chris, would you like to answer that one, please?
Thanks for the question, Martin. It is one that's been discussed at this committee previously, and it is an area that we have undertaken work previously and are continuing to do so. It's worth noting that the absolute numbers of people returning to hospital are relatively low. They're in the single figures per week, or if not much more than that. So they are relatively small when you consider the whole throughput. So relatively small changes in that number can result in percentage changes that are a little bit higher. That is not in any way to diminish the impact on people who are discharged and then return. The further thing I would say is that the the data that backs this particular indicator doesn't differentiate the reason for people returning. So people could be discharged as a consequence of one particular episode and readmitted with something which is entirely unrelated to the thing that they were in with first, and that would still count as one of the statistics. So it is a complex indicator. I can give some assurance to the committee that the absolute numbers are relatively low, but above all else, it is taken seriously. I met only last week with our clinical director and discussed this particular topic, and there is some work and research going on in that area.
Thank you for that.
Martin, can I just thank you, Chris, for that. I mean, I would endorse what Chris has said, and also the question you've asked, Martin, because I think readmissions aren't always necessarily the same thing, but the impact upon the patient can be quite significant. And the only other thing I would point out is the indicator 19 is, I think it's probably as much to do with making sure there's a care package in place for people to get home, from hospital when they're ready for discharge. So I think although the two are compared and there may be overlap, but there's probably two distinct things, if I'm right, Chris.
Yeah, yes, they're not necessarily connected with one another. It's easy to draw the comparison, but I'd be cautious in doing that. That one's not necessarily related to the other. The indicator 19, 29.3% reduction in delayed discharge indicates very good performance, and getting care packages in place at the right time is absolutely part of that. But it's part of a wider pathway, which has undergone significant amount of work over time, and that work will continue.
Thank you, Chris. Martin, your next question.
Does
that answer your previous question, first of all?
Well, to an extent it does, but there needs to be something that for me is saying, well, yes, it's a low amount, but you could either say readmit it with the same, or knew that there could be a tag put on whether people are coming back with the same problem or with a new problem. I guess it may create a lot of work for something that's not really necessary, but just something I picked up on.
Thanks, Martin. I couldn't agree more, actually. I think that the readmission is never pleasant for anybody, no matter what the reason. So I think it's certainly something that we can have a look at and try and get more information for the future. Jackie, you want to come in? Thank you.
I think just to say that this, and quite rightly, as you point out, Martin, is an area of concern for us, albeit we're talking about smaller numbers of people. That's not the point. The point where this is avoidable, we should be understanding what might support a much more effective discharge for people. So I think you're right, and it's an area where the Health and Social Care Partnership will focus some activity to see where that can take us and learn from that, and certainly drill down more deeply into that. But I just wanted to also mention that I know members of the IJB and some members of this committee will have attended the frailty unit at PRI, which is an attempt to reduce admissions in the first place. So looking back, this is looking back over 23-24, but I think what we should be seeing is some improvement in that because of the addition of the frailty unit at Perth Royal Infirmary in particular. But certainly, yes, we will be taking a closer look at the the readmissions to hospital within 28 days, because there's also another statistic that we can look at locally, which is around those people who are readmitted within 7 days of discharge, which is actually even more of a concern. So we need to learn the lessons from that. So certainly we will be looking at that.
Yes, I think that'd be a very good point, Jackie. Martin, before you come on to your next question, can I invite Monica? I think she wants to come in at this point. Monica Dong.
Yeah, thanks. Hi. as previous clinical director for unscheduled medicine, so I manage the medicine and the ED teams in Perth, I guess just a bit of reassurance that every week any readmission is looked at and learned from, and the teams. So what happens is one of the PAs looks at all of the readmissions for 7 days and 28 days, highlights it to the consultant who was responsible, who goes back and reviews whether or not that readmission was avoidable or unavoidable. 98% of them are unavoidable. They're usually not related to the reason that the patient was discharged. If they are related, it's often a patient who says, for example, they don't want a care package at home. We already almost know that they won't manage at home without a care package, but we have to do what the patient asks. It's person-centred care. It's what they want to do. And then unfortunately that discharge fails. And a lot of the time then there's a wait then for a package of care. I think the other thing is we've got to think about the improvements that have been made in terms of what happens in PRI round about the ambulatory area. So we may discharge patients home who say need a blood test in 2 days. Instead of keeping them in the hospital for 2 days, they go home, they come back in for a blood test. Because of the way that's tracked on the system, that's classed as a readmission. But actually it's a planned reattendance, it's not a readmission. So we've got to think about the ambulatory area, and although that's making improvements for patients, the way that it's captured in terms of the data puts it through as a readmission. So there are national conversations going on around about that data, how it's captured and how we can improve the reporting of it, because actually there are some inaccuracies just round about the way that the data is captured. So just some reassurance from that.
Monica, can you put your mic off, please? Thank you. Martin, does that answer your questions on that particular aspect?
It's more an explanation, but if we were recording that would make it clearer, and I welcome that's going to be looked at. My last question, it's not really a question, it's an observation with me and charts, like, and then it's a feedback for the strategic plan consultation. And it's shown 72 participants are neither satisfied or dissatisfied. What is that telling us? And I'm not a person. You're either satisfied or you're dissatisfied. I'm not a fence sitter, and I just wonder if that could maybe any future thing take that sort of neither satisfied or dissatisfied out. That's only for me, look.
Thank you, Martin. Chris, would you like to comment on that, perhaps?
Yeah, thanks, Martin. Yeah, there's sort of two schools of thought on that. One is that the consultee doesn't have the opportunity to, as you say, sit on the fence and they've got to go on with the other. The other is that there's an opportunity for people to have that balanced view. I'm not sure there's more I could say about what the right or the wrong way is to do that, but we can certainly speak with other colleagues and elsewhere to see if there's a preferred way for everyone. Thank you.
Thank you, Chris, and thank you, Martin. Are there any other questions or observations or comments in the room first? No, and online? There doesn't seem to be. So in that case, we'll move on to the next piece. The purpose of this report presents Perth and Kinross's Integration Joint Board's annual performance report for 2023-24. The annual performance report set out performance in relation to the national core suite of integration indicators and provides an overview of progress in meeting the Integration Joint Board's strategic delivery plans, focusing on impact and the experiences of people who use health and care services. We're recommended as a committee to approve the annual performance report. Do we approve the report? Very much. Before we close, I would just like to thank all the officers for the amount of work and effort that they've put into this report and the preparation of it. The fact there are so few questions, I think hopefully it goes some way to the testament of the previous chair of this report, Mrs. Beth Hamilton, who was the chair for most of this period, and to the amount of information and detail that has been shared at previous committee meetings. So thank you to the officers and to Mrs. Hamilton. And if there are no other comments or points, then I will close the meeting and thank you all for your attendance. Thank you.